life. And so for her, a lot of places for her psychologically, that is how she feels. This picture is someone who's dear to all of us, I imagine. This is Robin Williams. It says, read it twice. Every one you meet is fighting a battle you know nothing about. Be kind always. Kind of the motto of our conference today, right? We're really looking out just to take care of one each other, be kind to one another, notice that all of us are on our own journey, and that if we could all just be a little bit nicer, I think the world would be a very different place. I was a little bit troubled when I sat down to write this talk for you because I didn't really know where to go with it. I had a broad topic, health concerns in the older adult, right? Mental health concerns, very broad topic. And so I'm hoping, that's why I asked for questions. I'm hoping I nailed the things you guys wanted to hear today, but I don't think of a lot of the mental health stuff in the older adult as all that much different than the young adult or the teenager. It's a lot of the very similar stuff. And if people have had tendencies to have anxiety and depression throughout their life, they have tendencies to have that in their older years as well. The problem, though, is that through the years, there hasn't been a lot of research on the older adult. And so if I go back into PubMed and I do a 5-hour search and I'm trying to look at all of the research that's out there studying the older adult, a lot of the research started in the late 1990s. And so we've had about 20 years of research on the older adult. We do know that anxiety and depression, they affect the older adult just as much as they affect the younger adult. But there was a lot of belief for a long time that as you grew older and wiser, it didn't affect you anymore. You were less likely to have anxiety and depression. In my practice, I don't see that. I think people have the same types of stressors and they are just as likely to suffer from anxiety and depression. Some of the statistics do say that there is probably an incidence of about 10% of people suffering over the age of 65 with anxiety. There is probably a 6% prevalence of depression. I think those numbers might be a little low, and I think they're low because we don't screen enough. You go on to mood disorders. So mood disorders, such as a bipolar mood disorder, one of the things about bipolar in the older adult, and we may have already talked about this a little bit, is that a lot of people who suffer from very severe mental illness do not live to be older adults. They often die about 20 years earlier than the lifespan of an adult who does not have a diagnosis of bipolar disorder. And so that's one of the things about our healthcare system right now is if you are managing and caring for somebody who's been diagnosed with bipolar, they have to take medications commonly that do affect their physiology, correct? So we have to screen for diabetes because they're more likely to develop diabetes. We need to definitely be watching their liver and kidney function because sometimes these medications can take a toll. And then, of course, we know that there are lots of behaviors that go along co-occurring with the diagnosis of bipolar, which often do lead people to not live the full lifespan. I've been fortunate enough in my day to take care of quite a few people that have lived into their 70s, 80s with a diagnosis of bipolar. All of them, yes, had diabetes. They took their antipsychotic medications and all of them had diabetes. Most of them have COPD because many people we know have used tobacco through the years. And so it creates a complicated human with a physiology of needing many medications, lots of medical issues, and then still dealing with their chronic illness that they have had for a number of years. Schizophrenia is an interesting one. There is a group of people over the age of 65 that can develop schizophrenia. It is very, very rare, but it does happen. And so we have to have it on the list of concerns when we are screening and assessing people that come in with delusions, hallucinations, or things that could be presenting, such as schizophrenia. And then the co-occurring with substance use. Substance use doesn't go away as we get older. We know that there are many people that are suffering from all of the substances that we take care of through the lifespan. Opioid use disorder, alcohol for sure is one that I see a great deal of. And so we have to screen for those disorders as well. So how does someone who is having some trouble with their mental health present as an older adult? That might be a little bit different because when you are a younger adult, your memory typically isn't something that goes very early on in illness, but we have seen it. You've seen people who have depression or anxiety and their memory is not going very well because the brain is confused and it's frustrated and it's exhausted, and then your memory doesn't work as well. But in my practice, one of the things that people will come in to see is they are having trouble with memory. They just don't think the same. They can't recall names. They can't recall words. And so, high on the list is to screen for all of the behavioral health concerns. Anxiety and depression needs to be ruled out first before you chalk it up as any type of dementia or Alzheimer's disease. You'll see changes in personal care. Somebody who maybe never left the house without having their hair done, their lipstick on, dress on, may come in with their hair looking like it hasn't been brushed. They seem a little bit disheveled, and that commonly can be one of the only presenting signs when somebody is in my office and they are experiencing anxiety, depression. Social withdrawal is huge, and after these last 2 years we've gone through, it has been a huge challenge because the seniors, especially in our community, have been very holed up. They have been spending a great deal of time at home. They haven't been able to get out and do their regular social interactions. And this is a part for me that has been the biggest struggle with COVID is just knowing that as humans we're very social, and when you take somebody who's in their 80s and you eliminate their social interaction, you can watch them age 5 to 10 years in a matter of a couple of months, and it has been devastating. Changes in mood and personality. So anger commonly is something that you'll have family members telling you about someone when they're in the office. And so this would be another very forefront presenting thing. The problem with anxiety and depression is many of us have a impression in our own mind of what it looks like. And to each of us, and especially if any of us in the room have experienced either of those diagnoses, it looks different for everybody. And so that's the point about these slides. These are just a couple of things that I might be honing in on if I have a senior in front of me, but it doesn't mean they're the only symptoms. The one that I notice the most is the increased healthcare utilization. So if I have a patient in my office that maybe is there to see me for the very first time, one of the things that I will do is I'll go and pull in their medical records so that I can see what they've been up to, who they've been to, what kind of tests have been done in the past. And if you see ER visit, ER visit, ER visit in the last few months, that is my first sign that something is really going on. I don't know what it is, but something is going on. And so anxiety disorder a lot of times presents as somatic symptoms, chest pain, right? Chest pain goes to the hospital on a whim because that's a heart attack. And many times that is their anxiety presenting. And so I can't even tell you the number of people in my practice I've seen over the years that, number one, they've been showing up at the emergency room with chest pain, and their issue is they are dealing with multiple life stressors and they have anxiety. So we're on the verge of a whole nother tsunami right now. So elders are living in homelessness. And this is something that as a system and as a community, we definitely want to think about and we want to look at very closely. It will probably be our most present public health emergency in our forefront. To live in a nursing home, it costs about $10,000 a month minimum. To live in an assisted living, it starts at the lowest amount around $4,000 and goes up from there depending on how much care people need. This is where most of the seniors in our communities end up when they're struggling, and that's the type of system we've put in place. Is it correct for some people? Yes. Is it providing them with all of the things that they really need to have a good quality of life and a fulfilling later stage of their lifespan? No, most of the time it doesn't. It can't. It's a system that is already being taxed and exhausted. So we do know that this number is growing. I don't know how well, oh, I didn't go forward with my thing. Sorry, guys. We don't know exactly the numbers of people in their older years that are living in homelessness, but there is a forecast that was put out. It was a big study that looked at 5 or 6 of the large metropolitan areas. And they pretty much said that that number in the course of 2017 to 2030 would nearly be doubling in all of those communities. And why is this? So, the supplemental poverty measure found that 45% of adults age 65 and older were economically vulnerable. And I think that's the part that I am stricken by every single day. People who are living on Social Security is their only form of income. Their property taxes are going up, the cost of gas is going up, the cost of food is going up, and the Social Security is not going up very much, or it's not keeping pace, right? And then the cost of healthcare on top of that sends a whole nother tailspin that we've never been able to get our handle on. So I have someone who's in my office, they're living on $800 a month. They have their check is basically maybe able to cover food, their utilities, and they have to consider which medications they're going to spend their money on. So it doesn't take very much in this group as well to be one step away from without housing. Correct. So they're very vulnerable. So again, all of our decision making, everything that we put in place, all of the policies, everything we're thinking about when we're talking about the senior is to be thinking about what is happening in the housing world because this is going to critically affect and it will affect all of us. I mean, if property taxes go up in the state of Montana at the rate they could based on the values, we'll put hundreds of people out of their homes. All right, so the number one question I get is how do you know if it's dementia or something else? So that's what I want to spend a little bit of the rest of this talk is a little bit about dementia. Um, it's hard to decipher, and at one visit you may not know. And so I did make a little list here that under dementia we think of memory loss, we think of them having difficulty performing everyday tasks, so such as following a recipe or driving the car to a place that you would think that they know very well, but because of the directions and the steps, they might get turned around. Loss of initiative or apathy is one of the very first commonly presenting signs of someone who is developing some dementia. And then, of course, their mood, they may be depressed and anxious along with the signs of dementia coming on. If we're just talking straight about depression, sadness, a feeling of despair, being able to talk about what they're sad about, being able to really reflect and have the insight to some of the stuff that's going difficult in their life, that's often more likely to fall under straight depression. When you have depression, though, you can have memory problems. You can be fixated on death in either of those groups. And so I would say at visit number one, it's pretty impossible to determine, am I dealing with depression or am I dealing with somebody who's got the onset of dementia? And does it really matter because we should probably be treating both either way, right? We're going to learn the difference over time. And so that's the important of also having people really understand the real need to have a relationship with counselors, medical providers, and have it longitudinal over time. So some of the specifics, and these are not unique to this group, but they are specifics that I wanted to talk about that I see. Long-term physical illness, so just having multiple of chronic illnesses can specifically really result in impacting health, mental health. When individuals have strokes, so after a CVA, there's a very high likelihood that somebody will have a bout of depression. And I think that makes sense. A CVA is an insult to the brain tissue, and not that all depression resides from the brain, but our neurochemistry, our neurotransmitters are affected from the brain, and so you will see a lot of depression after strokes. Social isolation we went through. The experience of ageism was another area that I wanted to just bring up, and the little diagram just talks about how much it happens, and so be a little encouragement to all of you, maybe if you watch television tonight or when you're reading the newspaper or when you just listen to people talk about others, there is lots of ageism out there, and we don't think it's that big of a deal, but I would bet everybody in this room isn't really that excited about growing older. It's not our favorite thing to do. So we struggle with the idea that we don't want to be old, but we do know it's inevitable and it will happen. So how we talk about somebody who is aging, how we look at this group of people, it does affect their psyche, and so it shouldn't be pushed aside. The loss of a spouse can be one of the biggest, huge transitions in a person's life. And so that's where I would say I most commonly see anxiety and depression is when there has been a loss of a spouse. Normal grieving is present, but you will see that people that go beyond maybe a year, or if in that year they are having thoughts of death themselves, those are some real big cues to be honing in on. And then we did discuss the financial burden, and of course, the retirement is another phase in our life where we think we're excited about it, we're going for it, we can't wait for it to happen, and then we forgot that we have all this time and we don't know how to fill it, and that can create its own set of new challenges to the psyche. And so it's really great to have a plan, right? Have a plan when you do retire, or don't retire. I mean, maybe just keep working. Retire now when it's fun. There you go. So again, this just goes through something we visited already on the anxiety and depression. The numbers are not huge, but I would say that some of the things that's specific, and this isn't any different than the stigmas we've already talked about, there is stigma amongst the older adult to even recognize that depression is a true diagnosis. And I think that's the conversation I'm having a lot. So in my practice, I want people that I see to work with the therapist that I work with. And to convince them to do that is really, really hard. I don't know why. I don't know if it's solid stigma. Yes, question. Yes, and I'm going to go through that just a little bit because you bet. I would say that every patient that I take care of through some phase of their dementia does suffer a bout of depression. I don't know if I can come up with a single person who started having dementia symptoms, stayed happy, go lucky, moved through the whole thing without any real signs of depression, right? I think at some phase or stage of the dementia progression, you will see a bout of depression. And so I treat most people, and I use the recommendation of the therapist to do the CBT with them for sure. Like get right in and talk about the things that they they can reason and capture and think through, which is a smaller piece than maybe if you were dealing with someone without depression or dementia. But I really do believe that you can use those same techniques and help people to make small changes, things that they are still capable of managing. And the loss of control, right? Losing control when you have dementia, especially the early signs and symptoms, is the scariest part. And so focusing in on the things they do have control over and making sure we help them to maintain as much control for as long as possible. All right. So we have talked about suicide. Thank you. Talked about suicide in all of the different populations. This population is not any different. The rate of suicide in the older adult is about 17 in 100,000 individuals, and that number goes up exponentially when you're talking about the group of people 85 and older. That number can be as high as 65 per 100,000. And so, what happens in the oldest of the old is that sometimes it's underreported or maybe not recognized because they are doing what we call as passive self harm. They may start restricting and not eating. They may stop taking their medications purposefully, may stop drinking with the whole hope that they will expire. That is the goal. And so, in my role, it's really challenging. You're trying to help people have quality of life and transition into the dying process naturally and comfortably, but we're not trying to hasten it, right? And so it's having a lot of dialogue around what are their goals, what things are they still willing to participate, not participate in, and then go back to some of those techniques that the therapist can use so that people can find joy. There is lots of joy at end of life. I have seen multiple experiences of tons of joy at end of life. And so I think it's having people just be able to find that little sliver of hope and get through the suicidal thoughts that they might be having. Firearms are definitely the concern, and men are more commonly taking their lives than women in this older age group. So how do we treat it? So we'll go back and then we're going to spend a little bit of time on dementia after I just go through anxiety and depression again. So for sure, promoting socialization is number one. In all of the data that is out there, socializing for the older adult is the best medicine. So trying to help people find the venue. I'm very grateful in Butte for the senior center. Lots of people spend time at the senior center. They find a group of people there that they can have great dialogue, share a meal with. And so any type of venue, and this is where we have lots of conversations with families about, you have a big family. Why is there no calendar or no schedule set so that people in the family know it's my day to go over and see grandma? We can put things in place pretty simply to make sure that people are getting the socialization that does help with anxiety. Anxiety in the group of 90 plus is probably the thing that I spend a ton of time on. And so I will watch a woman in front of me who is made it to 90, so she's been most likely well adjusted and had a fairly good life from the standpoint of her physical health. Um, at 90, you start to see just the whole body kind of shrink, right? The brain is shrinking, the muscle mass is shrinking, they are shrinking before your eyes. And as that happens, this whole aspect of socialization seems to be the number one thing that we can put in place because the time alone, the evenings, the long nights, the darkness, those are what create the most anxiety for this person. And so I had a patient just recently who passed away. Her daughter had hired people to come in and spend an hour in the morning, an hour in the afternoon, a couple hours in the evening. And that one thing that she did made all of the difference. We were able to eliminate almost all of her medication because she just needed the socialization. All of the therapy modalities work, and that's not my expertise, so I let the experts continue to work on that. But I would say that making referral to therapy is huge. The reason why seniors don't go uh, to their therapy appointments, in addition to the stigma, is that it costs them money. And so a lot of times that's the number one complaint that I will get. I would love to go, but it's too much out of my pocket. I'm living on a fixed income, and to see somebody a couple of times a month, pay my copay, it's more than I can afford. Medications, of course, is some of the stuff that I will look at, and the number one group of medications is the SSRIs, and so fluoxetine, sertraline, venlafaxine, those are my go-tos. I try to avoid Paxil because Paxil has an anticholinergic effect, and that is not so good for the older adult. It can cause sensorium changes, which would be delirium. It can cause constipation, urinary retention. And then I use a bit of Buspirone, Buspar. Buspar itself, I have never found to be a hugely great agent in my younger person, but in the senior, there are lots of people that do get great response from it, and you'll notice it fairly quickly. And then there are times when you do need to use the benzodiazepines. The biggest risk with benzodiazepines is falling, and so you have to be very cautious with this group of people around falls. The same medications are true for depression therapy as well. You need to definitely be assessing for suicide. As we just talked, that data is pretty high. And then with all of your SSRIs, from a clinician standpoint, I do follow-up laboratory testing because you can get hyponatremia pretty quickly in the older adult when they start on an SSRI. And hyponatremia looks like delirium in your older adult. They can become very confused very quickly. So the rule of thumb is to start slow, and go low at first and gradually ease into it. But many seniors will need the same doses as your teenager does when you get into full therapy. So just just a few tidbits about how we treat. Okay, so cognitive impairment. So there are multiple kinds of dementia. Dementia is the umbrella, right? It's the big term, and in that umbrella there are multiple pieces of. I like to think of the little wires coming off the middle. Multiple different kinds. The number one most common kind is Alzheimer's. Alzheimer's is still the most common. The second most common is probably vascular. So Alzheimer's disease is in 1 in 9 Americans over the age of 65. And when I talk about people over the age of 80, it's probably 1 in 5. And so this is a huge issue that we are dealing with this older population and the increasing numbers. Oops. Frontotemporal dementia is rare, but when it happens, it's pretty severe. You will see that there is a lot of personality change, and it commonly happens in people fairly young. So you'll see somebody in their 40s, big personality change, probably have to put dementia on the differential of what could be going on. And then Lewy body dementia. Lewy body is common. I try to give one term that helps people know the difference between them. Lewy body is hallucinations, and so when we talked about new onset schizophrenia, when you're also talking about body dementia, people will oftentimes have a lot of visual hallucinations. Um, Early in my practice, I remember visiting with a woman, and she felt that there were people in her Christmas tree. They left the Christmas tree up all year, and she thought that there were men in the Christmas tree. Every time she walked by her large picture window in her living room, she would see people in the reflection in the window, and she thought that that was people inside her house. And she was terrified. So she lived alone, and this was the onset of her Lewy body dementia. Terrified that were people were in her house all of the time. I see a lot of vascular dementia and Alzheimer's disease together. And the reason why is because vascular dementia is like our heart attacks and strokes, right? So it's like lots of little micro strokes that are happening to the brain. It may present quite suddenly, a drastic, quick change, and somebody's different, and then they might plateau and stabilize there. And then they might have another micro event to the brain, and then you'll see their decline drop again. But those two things I will see going on simultaneously at the same time. And then Korsakoff dementia. Through the years, the Korsakoff dementia patient is absolutely the one that I enjoy taking care of the most because people miss it for about 10 years, it seems like. And so this individual typically has had a long-standing history of alcohol dependence. They oftentimes are confabulating, so they're telling lots of stories, big stories, and living the story in their brain like it is what's happening. They can tell you a very large story, and then you can leave the room and come back in, and they may not even remember they told you the story. And so we're starting back over, and they don't look like typical dementia, so they don't seem to have the same type of memory. If you give them the mini mental test, they will probably pass it with flying colors, 30 over 30. They won't miss one of them. And so screening for alcohol in your senior is critical. And then spending some time talking about things and then asking them to ask you questions back is a really good way to start to fine tune whether or not you're dealing with a Korsakoff dementia. So a workup, a geriatric assessment, this is the thing we talk to my students about all the time. So geriatric assessment includes thinking about the whole patient, which is why I enjoy this field. You want to think about, are they having falls? What's nutrition like? Depression? Do the cog eval? Look at their social determinants of health. You have to really kind of take in the whole person in order to get a good assessment. If I focus straight on their high blood pressure and their COPD, that's all I do in the visit. I'm going to miss about 90% of what's going on with my senior. Having the conversation around goals of care and being respectful about goals of care is something that our culture really needs to step up and figure out because we're not doing it very well. People aren't following it very well. We're not spending enough time getting things in place so that we can respect how people want to age. And then if you're doing a dementia workup, just the basics things that I would do probably right off the bat is I'm going to check a B12. I'm going to look at the TSH. I'm going to look at a folate. We're going to definitely talk about whether or not we're going to image the head. So you want to rule out a cancer in the brain. You want to rule out certain things that, are going to make a whole different course than dementia. But there isn't any one real specific thing on a CT or MRI that's going to totally tell you this is dementia. They might have some significant atrophy going on, or they might have lots of those little microvascular injuries, but it's not always going to be a clear cut, this is dementia. It's going to help you rule out the other things. And then I draw an ammonia just because ammonia is that encephalopathy piece that if you're talking about the Wernicke-Korsakoff, you may start to see that people have raised ammonia levels. There's a lot of stuff out in the literature that says that you can genetically test for Alzheimer's disease. It's called the APOE4 allele, and you can. I don't know that we have enough data out from the research that tells us what to do with it. It's currently not being paid for by insurance companies for that reason. We don't know what to do with it. So people do come in and ask. I have tested 2 people in my career. Most people, it's not high on their priority list when I see them. But people are very fearful of developing dementia, so they want as much education as they can get. Um, Truly, safety issues is probably where I spend most of my time. So, the driver who has cognitive impairment is the hardest talk. I've had many people leave my office cussing and screaming at me and telling me they're never going to come back to see me. And that's usually what it gets it is the driving conversation. So, you have to be very cognitive of safety. I had an uncle who drank Drano in his car when his wife went into another store. He was waiting in the car for her, and he thought he was drinking a gallon of milk. He didn't make it. So you have to really think about what are the things that are going to impact someone's safety. Wandering, living alone, all of the conversations that we need to have because safety comes first, right? We have to make sure people are safe. And then don't forget the caregiver. Caregiver's given up a lot, and to be a caregiver of a dementia person, this is where our social supports need to be in place. The Area Agency on Aging does have some funding to help with caregivers if they need some assistance to have some respite time. There is some support groups that are at our assisted livings here in town, but there's not enough services for caregivers. And if people don't have large families, I don't know how people get through a month, a day, a night sometimes with someone who's struggling with dementia. So the treatment for dementia is what I would call a multifactorial approach. It is basically healthy living, right? I mean, we don't have any perfect answer. There's a man named uh, Dale Bredesen. He has put out something called the MEND protocol. The MEND protocol is probably getting the most press right now as our assistance because, in my mind, I think that the huge rise in dementia is a couple fold. Number one, we're living longer. That's probably why we see the numbers huge. Number two, we have the standard American diet, which is probably not that great for our brain. We are less and less active, which is definitely not that great for our brain. And then we have spent a gob of money on pharmaceuticals, which who knows? Some of the pharmaceuticals that people take on a daily basis are also not that great for their brain. And the one that I notice the most in my practice is Benadryl. Tylenol PM helps me sleep, and I have a sleep disturbance. And sleep disturbance is one of my first signs that my brain is not doing well. So I take some Tylenol PM, and now I have a bunch of anticholinergic on board in my brain, and that's not good for me either. So all of these things are the approach to go back and now do we how do we control it? So Dale Bredesen thinks that everybody at age 45 should get what's called a cognoscopy. They should go in and have their cognition evaluated very deeply and then make behavioral changes in their life to go ahead and help start preventing dementia from developing. So yes, nutrition is very important. That's probably the one area that he talks about the most. They call dementia or Alzheimer's type 3 diabetes because of the sugar that is bathing our brain. So if we could reduce our sugar intake, we might start to see that huge wave of Alzheimer's that's upon us start to decline. This little picture here is the newest medication that has been recently recognized by the FDA, Aduhelm. It is very, very expensive. They haven't decided Medicare if they are going to cover the cost of it yet. It's probably about $15,000 a month. Um, the side effects that they are seeing with it right now have to do with people having brain bleeds, so hemorrhagic strokes is the number one side effect with it. And so the data is still out as to how much impact it's going to make. You know, we haven't been able to follow people for 10, 15, 20 years to really get an idea if you diagnose someone very early on in their cognitive impairment and you put this medication on board, what does it do for the course of normal Alzheimer's development? So something to watch. I'm following it. I'm not prescribing it. I haven't prescribed it. I have been asked, but I think at this point, the cost, the fact that it's not being covered, and some of the side effects are a reason to give it a little more time. They've brought a lot of medications to market with for the treatment of Alzheimer's and dementia, and none of them have really proven to help us in the way of a cure. There is no cure at this time. So we continue to go back to our MEN protocol, and it's about lifestyle. It's about taking care of your stress levels. It's about managing your social interactions. It's about diet and exercise. good quality of life living, I think that we could say for every diagnosis we get up here and talk about, right? This little diagram, which I'm sure you can't read a word on it, it's really just in there to talk about is the clinical dementia rating scale. And so one of the hard things goes back to driving. I always get asked, when do you take away someone's driver's license and how do you do it and what do you make the determination by? This is the tool I use. So it goes through and it looks at 6 different areas of our cognition and you rate people based on those different areas of the cognition. And if somebody has a score greater than 2, it needs to be a real conversation with the family. I can send a letter into the DMV, the Motor Vehicle Division, and tell them that somebody needs to be retested, meaning that they have to go in and actually take the test and drive for the screener. But people don't do that, right? They're just going to keep driving. So if you don't have family buy-in, that's going to be your second next most important place to go. And then you need a lot of family buy-in to help people with the rest of the safety areas, such as wandering. In Butte, Montana, wandering really scares me, especially when we have 20 below nights and people leave. And there have been a number of seniors in our area that have froze to death because they've gotten out and they got confused. And I came upon one of those even this last winter. I walk my dogs every morning, very early in the morning, and as I was walking down the street, a man was sitting on the sidewalk and he didn't know where he lived and he was hypothermic and it was scary and it can happen very quickly. And so I think those are the 2 biggest areas, the safety stuff that I have to spend a lot of time screening and discussing. I don't know how I'm doing on time. Am I almost out? So neuropsychic psychiatric symptoms of dementia. So agitation, delusions, hallucinations, paranoia, wandering, depression, apathy, sleep disturbance, anxiety, and somatic symptoms. Somatic symptoms are one of the biggest ones, and this is one of the reasons why we miss it. People come in, they're feeling terrible. It goes back to that story about the ER visits. They come in, they're feeling terrible. They don't know how to explain it. They don't know what it is, but they just don't feel right. Things are out of sorts. Their stress level is high. They can't manage the books, the driving, the relationships. All of that is becoming too much. And that's where we start to really hone in that there may be a true cognitive impairment occurring. For teaching caregivers, all of you, myself, people, there are lots of tools of how to help and interact with people living with dementia. Distraction and redirection is, I can't say it enough, it's a very important tool. You oftentimes cannot reason. People cannot reason when they are at this place of this illness. And it is so critical that we learn how to distract, get people's attention onto something else. That's usually the number one tool to de-escalate. Um, Structured routines are also the second piece. It's almost like going back to saying getting up at the same time, going to bed at the same time, making sure there's bright light in the morning, making sure as sun goes down, the daylight is gone. Now you bring on your inside lights and you transition to talking about it's nighttime. Reorienting, those are things that really do make a huge difference. I like to use a lot of music therapy, pet therapy, and aromatherapy. The research says that none of the medications are effective. That's what the research says. None of the medications are effective. We use all of them all of the time because I'll tell you what, the behaviors are so challenging for caregivers that if you don't do something, what's the point, right? So I do use a lot of medications. I use SSRIs and I treat depression and I treat anxiety. I use antipsychotics when I have to, but sometimes antipsychotics are the only thing that are going to help get a sleep cycle back on track. And so if you don't get someone's sleep cycle back on track, days are going to be miserable. And then we use anticonvulsants, and this is a category I'm trying to move more and more away from. It means like gabapentin and Depakote. And the reason why we use them is because those medications, what do? In the seizure brain, there's lots of firing. And this is almost how I describe the dementia brain. There's lots of firing, there's lots of stuff going on, but the connections are not meeting up because of the plaques or whatever is blocking the regular neural pathways. So when the connections don't meet up, people get confused, they get agitated, they get irritable. So by using the anticonvulsants, all that really does is it slows the sensorium down just a little bit so there isn't quite as much fighting or so much firing. So you might see a little bit less anxiety. You might see people be able to rest a little bit more. The bottom 2 meds are methylphenidate. You'll see people who are truly not moving or doing anything. They're not having much quality life because they're so apathetic. This is early on in the disease. People can be quite apathetic. A low dose of Ritalin in the morning does make a difference because it helps people get the energy to at least have some gumption to keep on going on with life. And then the dextromethorphan quinidine, that's kind of a newer medication. They're very low doses of both of those meds combined into one pill. I've tried to use them separately and it didn't seem to work. And so this one actually goes at a lot of that agitation that you can see. I think this is my last slide. So this is just about wellness and aging. These are the things that we as a community really need to do to help improve the wellness of our seniors. So we want to promote a sense of belonging and life purpose. So helping people to find places to volunteer if they live in a senior center or in some type of living center, projects, things that people can do to be a part. All of us want to feel like we are contributing. That doesn't change. It doesn't change from the time you're 1 and 2 to the time you're 90 and 92. People want to be a part of the group and they want to contribute. Social interdependence. So they want to be independent but dependent on the group, right? So it's kind of trying to figure out how do we make that mesh. We respect their independence, but we bring them and include them in the group. Physical activity and independence is huge. And so physical activity sometimes, and this is crazy, but sometimes they say, even if people can't stand up, walk, and move the way we think of moving, having people do face exercises is enough of that stimulation of a muscular firing that it does give the brain the same impulse to the brain that's that endorphin. So you can teach people, smiles, move the tongues, puff out the cheeks, shrug the shoulders, things that you can do without having to get out of the chair. Great nutrition. I'm in and out of all of our skilled facilities, and I will tell you, once you get to living in a type of environment where you are eating at the institutional level, nutrition is next to impossible to feed that many people and still make it healthy. But I would say it goes back to very simple basics: fruits, vegetables, lean meats, and trying to avoid sugar. The problem is that the older adult really likes sugar because that's the part of their taste buds that really still work. And so you will see people eat a lot of sugar. And then, as we can say, we're sitting here today and we're doing education on aging. I think we could have more and more of that. So that would be a huge thing to make our healthcare more sensitive to what's happening to the older adult. Nothing bothers me more than one of my seniors gets transported to the emergency room. They have dementia. They don't have a caregiver present. That's the time in my life where I'm just thinking, I'm going up there, I'm going up there. And I never go. I just want you guys to know I never go. I want to go every single time because I think that must be the most scary thing for an individual to go through. Walk into our healthcare system without somebody that they know, trust, to be poked, prod, tested, and to be out of their element. So we have to continue to look at our healthcare system and make it as sensitive as possible. All right, I'm done. Kind of questions? I ask everybody, are your firearms locked up? That's how I put it because I assume you have them. I don't know if you do, but I assume you have them. And then that way that opens the door that I'm accepting because I think in the doctor's office right now talking about firearms is a pretty political conversation. And so I just assume people have them and then I just ask them if they're locked up. In my house, all of my firearms are locked up. I have lots of guns. They're all locked up. But I want people to understand it's important to have the safety component. So if we can open the conversation, then we can say if they're not locked up, we have the access to get them gun locks. They don't have to go through the process of buying a big expensive safe, but in our clinic, we can get people gun locks. And so just assume they have them. So I always encourage my family members to send me as much information as they want. So you can always send it my direction, right? And then the more I am aware of what's happening, then truly, and this is not an easy part of a job, but there is a true capacity question, right? And this is what goes back to the driving and everything. You have to have capacity to truly make medical decisions. And so that might be where I open it up with the patient, is I just start to say, I think this stuff is getting to be a lot. Like there's a lot, and I talk about the stressors, and I say, wouldn't it be great if we could just remove one of those stressors and we try to take it a piece at a time? And that's where I might get buy-in from him, right? He's sitting there and I'm talking to him about all the stressors he's dealing with. And sometimes the one they will go for the most is just to let one person in to be a part of the decision making with them. And so I always ask that. But I encourage families to send me stuff until we can get him to the point where he's willing to open it up. Most of my patients, they get signed up as the proxy on my chart, and so we're doing a lot of dialogue before and after appointments, but then they still have the ability to go into the appointment and have their autonomy and their time with me alone. So those would be my tricks. I don't know if they'll work until they absolutely have to. Yes. Well, pain is hard, right? Because we have opioid use disorder and we have pain. And I'll be honest, I prescribe a lot of pain medication because they're the safest pain relievers for somebody who's suffering from very severe osteoarthritis. Um, I look at opiates the same way I look at antipsychotics, and the idea that you might go up on a medication until someone is controlled, and then you might slowly start to wean back down off of it so they don't use as much. And then you're looking at your other modalities to continue to work on treatment of depression in addition to the pain control. Most all people that I take care of are on Tylenol scheduled if their body can tolerate it, and that's mostly to mitigate how much opiate we have to use. But we do prescribe quite a bit. We all know some of the pros and the cons of opiates in the brain, right? But they are the safest pain reliever for an older person when it comes down to it. As far as comparing to like ibuprofen, you can only do so much with Tylenol, and so they do get used. I don't know if I answered your question. It's complicated. Yep. So vascular dementia can present itself anyway, and this is why. So if vascular dementia is caused by micro strokes or even maybe a major stroke to a part of the brain, the way it presents is probably going to be the part of the brain that it affects. So if it affects the broca and the ability to communicate, it may present strictly as aphasia. They may have more trouble with their words and being able to talk. If it hits, the same areas that you're dealing with Alzheimer's, your frontal temporal stuff could be affected. If it's going to be micro strokes up here. If it's hitting in the cerebellum, you might see a lot of ataxia and balance issues coming on before you're really going to see a lot of the maybe memory or cognitive things that you think of. Spatial awareness can be a part of that too if it's hitting more of the occipital. So it depends on the brain where it hits. Um, I had a woman who had a fairly large TIA, and then she really, her capacity to remember short term and long term was almost completely knocked out. She didn't really develop the rest of the phases of dementia for years. I mean, she lived 20 more years after that. And I never saw that kind of 10-year progression of dementia that you see with most people. So vascular is the tough one. They can be micro amounts, they can be big strokes, different parts of the brain, and it's really just about getting to know somebody and asking lots of questions. And if you see MRIs, most MRIs are read with microvascular disease present. So most of our brains already have little bits of it going on. There's very few people that you'll see at MRI and it doesn't say that. Yep. So for us, we do have both of our assisted livings have support groups, and I do encourage all of them to find a way to get to the support group. They will do daycare out at the Springs too, so if somebody needs to have an afternoon or a day off where, their senior can go in and spend the day there, but not be living there or spending the night there, they are open to setting up an arrangement like that. Even if it became every week, you went on Tuesday in the afternoon, you could go into daycare. The area agency has some funding for respite, so that would finding the person to come in to do respite, but there is some money for it available. And then, of course, the Alzheimer's Association online. There's lots of tips and tricks. There is a podcast by Teepa Snow. Teepa Snow is kind of the forerunner in the world of dementia, talking about caregivers and caregiver techniques. And so she's got a really great podcast that'll just go through on this is how you handle different behaviors and how you get through your day, and that can be helpful. I think really just trying to help people find support. So your senior companions, anything that would give somebody the opportunity to have some other support, whether it's just someone to talk to, someone to be at the house so that I can run to the grocery store today, those kinds of things. Yeah. Thanks you guys very much. I appreciate you letting me be up here.